Hello, so I'm going to try and talk about three different topics. We're going to go a little bit back in time. So first of all, to give you an overview of what the fight against involuntary infertility was in France before the creation of sperm banks at the beginning of the 60s and also the appearance of IVF a little later. And then I'm also going to talk about issues that we generally associate to genetics, biomedicine or technosciences, and the realities present before ART as we know it today, and then also give some historical context to talk about the principles of ART in France. So the first idea that I would like to emphasize is that not everything began in the 1970s, and that it was a century that public service medicine started to be interested in couples who were experiencing difficulty conceiving. We know that at the beginning of the 19th century, a series of studies demonstrated that between 5 and 15% of households could not conceive. And so public authorities were passive for various reasons, in particular for moral and political reasons. They preferred to fight against the voluntary restriction of births. But after the Great War, a certain amount of gynecologists and hospital workers thought it was time to develop a real diagnosis activity and, where possible, to provide therapeutic solutions. And that it was the arrival of the first outpatient consultations specializing in infertility, such as that of Louis de Vrennes, who created a consultation and outpatient service in 1925, and who would see several women in the 1920s, and then Jean d'Alsace, who created an outpatient clinic in the Jardin de Suresnes. And so this medical treatment, for the main part, was providing a series of examinations. One of the characteristics of the time was the fallopian tube permeability test, and this was a technique that used radiography and contrast agents to see whether, as in the image on the left hand side, the contrast agent that had been injected reached the fallopian tubes, in which case the functioning is normal, or on the right hand side there was a problem with the fallopian tubes. And so I'll go over all of the examinations that were proposed just to explain to you that when sterility was established and diagnosed, there were treatments at the time that were chemical, some were surgical, but the results are obviously limited. And what's I think here, we think that we can see this first wave of medicalization as being important because couples were more forthcoming as regards their issues conceiving. It was possible between the two wars to find people that would listen and who were more specialized. These professionals in the 1930s would try to ensure that a real public policy was implemented in terms of infertility treatment. There was the maternal and child protection, which invited those centres to propose fertility treatment. But the baby boom context was quite unfavourable because in this new demographic context, it was more difficult to hear the voices of infertile couples. The second consequence, and this is more problematic, is the potential of over-medicalizing the situation. And as Virginie Rosé spoke about, the obstacle course, this is something that we saw appear between the two world wars, that is to say, the more invasive examinations that did not lead to therapeutic solutions and that emphasized the care of women more than men, and women became sometimes guinea pigs of medical invention or innovation during the development of hormone therapy, for which there are still many grey areas. The third consequence is that despite the reluctance of men to present themselves and to go to these consultations, there was a light shone on male sterility more than in the past. And this taboo started to retreat slightly. And as Henri Léridon was saying, one of the solutions that would be increasingly developed for male sterility was artificial insemination, with or without a donor. And we know that in reality, since the 18th century, insemination can be done outside of the couple. Since the 18th century, some doctors started to carry out human artificial insemination, and this is used mainly with the sperm of the spouse to resolve any male sterility problems. However, it is also well known that this practice was rejected by medical authorities and religious authorities. We know why: because of masturbation, because of the disassociation between the sexual act and procreation, the involvement of a third person, that is to say the doctor, and then also the use of a donor, that is to say a donor that is different from the intended father. And this represented a form of adultery. However, there was an informal practice of artificial insemination and donor insemination in some clinics and also in some hospital departments. This practice, although it was not very accessible, there was the possibility of creating a case study of this unsupervised form of informal insemination. Well, the very few legal barriers, the very few constraints made it possible to couples who had resources, financial resources, to find solutions that were fairly flexible. Doctors started to offer their services, as you can see on the advertisement here on the screen. They would look for medical students, and this is something that worked quite easily for many doctors. So what were the drawbacks and all the other questions that would arise? Well, there are many. First of all, it wasn't insignificant that they were using medical students when you know the scientific culture and knowledge of doctors at the time. They were able to use a very selective pool, and this raises the issue of eugenics. The second point is that the functioning fell under a parallel economy, and that's what Professor Jean Bernard called the black market of sperm, and this leads to a series of questions, in particular as regards the diverse abuses, in particular the financial. And the third and most problematic point is a series of questions including sanitary risks, the responsibility for the doctor, and also the question of doctor-patient confidentiality and all of the problems that this can lead to. What should be said here is that up until the end of the 1960s, artificial insemination was done directly, that is to say, using freshly sampled sperm. But around the 1970s, thanks to cryopreservation, the United States would be able to create sperm banks. This is a storing system, a way to streamline the management of sperm and to ensure that sperm can be used in a deferred way for donor insemination. In France, several initiatives at the dawn of the 1970s did begin to appear. Some of them wanted to extend the informal system that existed. And one of those that would triumph is supported by George David, the founder of the Cecos system, and he proposed a compromise. On one side, it is very bold in terms of bringing into question the dominant thinking, but it also maintains the ethics and free nature of the solution and therapy. But it can also be used in a very particular context, and this was in the 1970s, where there was a significant wave of feminism. So this ethical system will be recognized by the public authorities as the only one being accepted, and this was due to the ethics law. And this gave rise to a French specificity, which is now brought into question by globalization. But compared to other radical systems, such as the sperm banks in America and Denmark, which are much more market-oriented and more hereditist as well. So here you can see some ads that are found on websites from the various sperm banks. So here we can see all of the various criteria. So we can see that this type of model was ruled out, but that there were still a series of questions that are currently at the heart of the debate. That is to say, the restrictions of married heterosexual couples, the status of children born from ART. The third is the efficiency and flexibility of a non-market-oriented system to coordinate supply and demand. And then also selection. That is to say, the fact of rejecting eugenics, and then other issues that are inherent to medicine, biomedicine, and genetics. Thank you.